one of the reasons why I became more interested in this topic, and that this topic has always been on the front line with cardiologists and cardiothoracic surgeons, is because there's been some new data over the past 5 years, but some very interesting data last year as it relates to therapy in patients with diabetes and heart failure. So I just wanted to give you an update on some new data that you'll might be seeing from your family docs or endocrinologists, or for that matter, your cardiologists and your internists who may bring this up to you. And you can go to the next slide. So I saw this little comment from the American Heart Association, and this data was just taken off the American Heart Association website and the American College of Cardiology website. But we have a lot of little sayings that we say in cardiology, and one of them is atrial fibrillation begets more atrial fibrillation. Well, this was interesting, where diabetes sort of brings on heart failure, but at the same time, heart failure sort of brings on diabetes. And that each of these conditions, whether it be fluid buildup from congestion due to a heart that's not meeting the needs of the rest of the body, which we call heart failure, can lead to diabetes. And at the same time, diabetes, specifically type 2 diabetes, can bring on the development of congestive heart failure. And it's not necessarily, as I've said in the past, it's not necessarily that the heart stops or the heart has failed. And there have been a number of the leaders who have actually tried to say, maybe we should take that word failure out of the lexicon of describing heart failure. But really what's happening is that the heart itself is not meeting the oxygen needs of the variety of tissues of the body, primarily the kidney, the gut, the brain, and the lungs, and the liver. Just like Dr. Baldy was talking about how dramatic the coronavirus affects systemically, the same thing can happen in heart failure as well. Both of these conditions, diabetes and heart failure, can occur together, where it clearly worsens a patient's health, their quality of life, and also, as we all know, increase the cost of care to the patient themselves, increasing the cost of the care to society as a whole, and increase the cost of care to the mechanisms that deliver the care, that being the hospitals and the offices and the providers that deliver that care. Next slide. The relationships that diabetes and heart failure actually has different power in different populations, in that women who have type 2 diabetes have a 4-fold higher risk of the development of congestive heart failure. Men with type 2 diabetes have a 2-fold higher risk of heart failure. So women are clearly more at risk if they have diabetes and their risk of congestion. And when you compare women to other women who do not have type 2 diabetes, those women that do have diabetes have a higher risk of heart failure compared to those same women who don't have diabetes. And the same goes for men as well. Next slide. And so what this has done over the past several years, it has really begged cardiologists, family practice doctors, nurse practitioners, physician's assistants, endocrinologists to really work together and to sort of get out of their respective silos and how they address patients, but try to cause them to work together to take care of you, to talk to each other, to recognize that we're taking a condition that is crossing specialties. We were trained, a lot of us in the medical and the surgical arenas, when we were trained in, we would go a certain path, we would start in a general path, but then we would specialize and go down other paths, learn our trade, but at the same time, avoid other silos or other paths because we were so focused on the conditions that we were trained to take care of. That's actually starting to change a lot in a lot of different specialties. This is one example where the endocrinologists, the internists, the family practice doctors, and the cardiologists are really all having to address the manifestations of diabetes. The cardiovascular surgeons, the vascular surgeons also have had to, and another big, very important two very important specialties, the ophthalmologists and the nephrologists, the kidney doctors, have had to all work together and address the various manifestations of type 2 diabetes. So we all have to work together to coordinate care. And I actually empower you, the patient, to ask your physician, nurse practitioner, various practitioners to take care of you, and ask them, have you talked to Dr. So-and-so? Have you talked to my endocrinologist? Can you reach out to my family doctor and see if this is all okay, whether your medication from a cardiology point of view is appropriate with a medication that the endocrinologist or the internist might be prescribing, or the nephrologist might be prescribing. And so this particular disease, diabetes, is causing all of us in a great way to come together to deliver the care. There's other examples where this is going on right now. Cardiology and oncology are coming together, in their various relationships, because there are so many cancer survivors now, thank goodness, who are now requiring cardiovascular care. So there's a lot of these subspecialties that are melding together in a great way to take care of patients like yourself. Next slide. What happens with the pathophysiology as it relates to diabetes? Meaning, when I say pathophysiology, what is the actual insult to the variety of tissues? Well, we know that one of the, if not the main problem with type 2 diabetes is noteworthy for, you'll hear these two terms, insulin resistance. And how I explain to my patients, and because I'm not that smart and I like to break it down and keep it simple for myself, I think of insulin as an automobile. And I can remember when I was growing up with not the computerized engines that we have right now, but I can remember going to the shop with my father and my grandfather, and we had that quote unquote 8-cylinder. My father worked for General Motors in North Jersey, and he prided himself on the 6-cylinder and the 8-cylinder engines that the Pontiacs and the Chevys used to have. But when the car was not firing that well, there might be a timing issue, and the car was not that well tuned in transporting us to baseball practice or for wherever we were driving at the time. And we would take the car in for a tune-up. But at the same time, the car would still function, but its efficiency in transporting the 4 kids around to the areas that we were going, that my mother and father would try to do back then. And as a matter of fact, we used to walk a lot more back then rather than getting into cars. And I think our insulin was actually pretty good compared to kids right now, but that's a side thought. But they would get their cars tuned up. And that's the problem with insulin. Insulin is a very important protein made by the pancreas that has a variety of responsibilities, but most importantly, transports blood sugar from point A to point B. We need blood sugar. We need blood sugar as a fuel. Our tissues require, our cells require blood sugar to have normal metabolic needs and normal metabolic jobs that they have to do to produce protein, to produce energy for those cells to work. Glucose, in and of its form, when it's freely sitting in the bloodstream, does not have value to us. It has value to us when it is transported to the respective cells by insulin. But if your car and or your insulin is not well tuned, blood sugar concentration in the bloodstream will rise. And that high insulin and that high blood sugar causes injury. That is the root cause of the tissue problem. That injury that is caused to the variety of tissues, we really talk to in a more sophisticated term, we call that inflammation. And that inflammatory process, which is the migration or the calling of white blood cells, certain type of cells that generate the development of scar tissue, we call those fibroblasts. That inflammatory process, wherever that may be, results in malfunctioning of those tissues and, in fact, premature cell death. So we're talking about premature cell death. Think of them in the highly vascular tissues, the brain, the eyes, the heart, the kidneys, the peripheral vasculature. We have this silent cell death at those tissues, the peripheral nerves, such that the manifestations that we hear on history and the manifestations that we see on physical exam are due to tissue loss at those areas. So that's why we ask our diabetics to go have their retinal exam by an ophthalmologist or an optometrist. That's why we ask we should know certain parameters when we have diabetes as our report card or as our checkup, so that we don't have tissue loss, cell death, or other more dramatic complications of diabetes, where suddenly a plaque in an artery, whether it be in the brain, the heart, or in the gut, that plaque suddenly changes. It exposes itself to the inner lining of the blood vessel, blood clots form, red blood cells and platelets form, and we have sudden lack of blood flow to that area of tissue. The mechanism of a heart attack, the mechanism of a stroke, the mechanism of how the heart can suddenly weaken or fibrose over a period of time, and the heart weakens or stiffens and cannot handle the pressure volume relationships and deliver the oxygen to the tissues, the definition of heart failure. Or the silent loss of the engine of the kidney, which we call the nephron, or the development of blockages downstream in the legs or in the mesentery in the gut. All of this can happen with unmitigated treatment or control of type 2 diabetes. Next slide. Who's at risk? Well, certainly the Warnicks are at risk. My grandmother had type 2 diabetes. My father had type 2 diabetes. I am at risk of type 2 diabetes because of my grandmother Warnick, and my father had type 2 diabetes. So I got to be careful myself with my weight and my diet. And so family history is very important for the development of diabetes. And those that are not necessarily obese or not necessarily leading sedentary lifestyles can still develop type 2 diabetes if their family histories are such. However, we have certain other populations of people, particularly in this country, African Americans, Latino Americans, Native Americans. We have a big Native American problem in this country as far as the development of type 2 diabetes, and Asian Americans. Also women who had gestational diabetes during pregnancy. That can be sort of an unmasking of what portends for the future. Or women who deliver babies that are over 9 pounds in weight. That can be a sign in the future of the development of type 2 diabetes. Next slide. So what is the report card, or what are the parameters that you should look at as far as, hey, I'm a little bit concerned. I got to have my heads up as far as the development of type 2 diabetes. I got to keep an eye on my blood pressure. I got to keep an eye that my blood pressure is at a very strict control. Ideally, I want it really in the 125 to 130 millimeter of mercury systolic or less, diastolics in the 80 millimeter, 75 millimeter mercury or less. I myself am on blood pressure medications. I'm on losartan, which is what Dr. Baldy talked about, an angiotensin receptor blocker in the first talk, because I feel that losartan and the angiotensin receptor blockers and the ACE inhibitors are very cardiovascular protective as far as controlling blood pressure but decreasing tissue loss. I go for my eye exam every 2 years. I want the ophthalmologist to look at my eyes and make sure I'm not developing any retinal disease, which could be a sign of diabetes. I want to know what my fasting blood sugar is. I want to know what my blood sugar has been over the past 6 weeks. We all are watching what the stock market is, on a daily basis, but we also want to know what the market has been doing in prior tough times over the last 6 weeks, the hemoglobin A1C is an indication of how your blood sugar has been over the previous 6 weeks. And your doctors really key on that hemoglobin A1C as far as how tuned or not tuned your insulin is. We're interested in your urinalysis. Think of protein that your body builds as a piece of gold. It took a lot of work for that gold to be produced. It has a tremendous amount of value. Gold or protein gets filtered through the kidney. We're not supposed to lose any protein in the urine or minimal protein in the urine. Signs of kidney damage from diabetes is loss of protein or protein in the urine that the nephrologists are often looking at. Steve, Mohammed, Chris, and I are always looking at the electrocardiogram. And we can pick up clues on the electrocardiogram for patients who may have diabetes. Diabetes can stimulate arrhythmias, a very common arrhythmia that we take care of called atrial fibrillation. And we can see signs of coronary artery disease on the electrocardiogram. We can see signs of a cardiomyopathy or a heart muscle problem on the electrocardiogram. We also key in on a blood test called the creatinine, or the concentration of a heart muscle enzyme that can only leave the body one way, and that's through the kidney. And we measure creatine as it's broken down in the kidney in a product, a serum blood test that we call creatinine. We're very keyed in on our cholesterol, because if someone has diabetes, sometimes they can have high levels of what we call triglycerides. And we're also very keyed in on, especially cardiologists and cardiothoracic surgeons, we're very keyed in on a strength number. It's sort of like our hemoglobin A1C, so to speak. We key in on a strength number of our left ventricle and how strong and or mildly weakened or weakened, and that's called the ejection fraction. So I challenge all of you to really look at this report card and look at these parameters as it relates to diabetes and cardiovascular health. And each one of us should really know what our blood pressure is, when we've had our last eye exam, what our laboratory criteria are, should we or should we not have an electrocardiogram, cholesterol panel, and if you've had an echocardiogram or some sort of other cardiovascular study, what your ejection fraction is. I challenge, be an advocate of yourself for your cardiovascular health to know these parameters. Next slide. What are the things that we can do that can, from a non-pharmacologic point of view, that can help tune our insulin? Get a tune-up of our cars, but tune up the insulin. We really want to try to stay away from those simple sugars, the refined sugars, the sugars that are the white sugars, as we say in the business, the short carbon sugars. Sugars are combinations of carbon, hydrogen, and oxygen. I did not do well in organic chemistry at Rutgers University. Thank goodness I got through. But sugars are organic chemical products. We like long carbon sugars, many, many, many carbons attached together. They're very difficult to break down. Those are the carbons that are in your complex brown breads, as opposed to your simple white sugar or white floured breads. So it's really the avoidance of those refined sugars that overtax your insulin. We really want to convert from an inactive lifestyle to a more active lifestyle. It doesn't take much. I've talked to a lot of patients via telemedicine over the past 5 months about walking. And I have to say, if you are able to walk, a lot of my patients are doing a tremendous amount of walking. A lot of my patients have lost weight. I've seen two populations. I've seen people who have gained weight, but I've also seen a lot of people who have lost weight over the pandemic, mostly because of walking. And they're being a little bit more health conscious at home, trying to avoid the simple carbohydrates. And just by those first 2 bullet points alone, they have lost weight. Walking and refined sugars avoidance. Know what your blood sugar is. If you are a diabetic, I know your practitioners are telling you to check your blood sugars, see what your fasting blood sugar is. A very, very important leading, a lot more is being seen in the literature regarding quality of sleep. Are you getting good quality of sleep? Avoiding the sleeping pills, assessing for sleep apnea. A lot of us have difficulty with our bladders at night, asking your urologist to help you try to see if you can urinate less at night so you can get quality sleep. But a sign of uncontrolled blood sugar is actually nighttime urination, or what we call nocturia, or a sign, interestingly, of uncontrolled or decompensated congestive heart failure is nocturia, or nighttime urination. So that's a red flag for uncontrolled diabetes or uncontrolled or decompensated congestive heart failure for excessive urination at night. I'm not saying frequency of urination, but I'm saying large volumes of urine at night. And like I said before, we really have to know what our blood pressures are. So these are the non-pharmacologic ways that you can address diabetes and heart failure. And I think I have maybe one slide left because I'm getting near the end of my talk. But what was the new data last year and over the past 5 years? You're going to hear more about certain particular medications. They are abbreviated because we love to abbreviate in our business, but they are the sodium glucose transport inhibitors at the level of the kidney, where they're shortened into the SGLT2 inhibitors. You're seeing the generic names called empagliflozin and dapagliflozin, but the trade names that you see are Jardiance and Farxiga. The Jardiance commercial has been heavily marketed on TV. It's the African-American band director that you're seeing, and she's conducting the marching band on TV. I've seen that a number of times during Phillies games lately. I teach about dapagliflozin only because it's going generic next year, and I think all of us, practitioners as well as patients, have to be aware of this. Why? Over the past 5 years, there have been major trials released about the improvement in cardiovascular outcomes in diabetics as far as decreased heart failure, decreased death, decreased hospitalizations when diabetics have been on these medications over the past 5 years. They promote both heart and kidney health. We initially thought that they were sort of quote unquote expensive diuretics by forcing the urine to go out by forcing the glucose to go out in the urine, but they actually do more than that. They are cardiovascularly protective and they are kidney protective. They've had unexpected benefits last year in that the trials included, interestingly, these quote unquote diabetic drugs in non-diabetics for heart failure. And those same patients, non-diabetics and congestive heart failure, had a benefit with these drugs as well. That was unexpected last year, and that was one of the blockbuster trials in 2019. So I wanted to give you that update that you may hear about these drugs from your doctors more in the management of both diabetes and heart failure.